Opportunity to revisit India, visits which I always enjoy enormously. For the next 20 minutes, I'm just going to cast briefly through the topic of diabetes and the brain. I'm mindful of the fact that the last two speakers have covered quite a lot of areas in relation to cardiovascular disease and diabetes, and I have tried, where possible, to avoid overlap. Obviously, the brain in diabetes is vulnerable to a number of different problems, and I'm sure you can read that list without any assistance from me. What I intend to focus on in this particular 20 minutes are the micro and macrovascular diseases, cognitive decline and dementia, and a little bit about psychiatric disorders and particularly depression. The other issues, you can just read the topics. I will not be covering at all, purely because of lack of time, you understand. This data was also shown briefly by the last speaker, or by Eberhard, and it looks at diabetes and non-cancer, non-vascular deaths in this particular example, and you can see from the highlighted lines that there is an increased risk associated with mental disorders, nervous system disorders, and also Alzheimer's disease and related conditions. It's important, I think, just to understand a little bit about the physiology. Obviously, the brain in particular is critically dependent upon glucose as its major fuel. Glucose has multiple roles in cerebral function. Glycogen is stored in astrocytes, which are one of the sites in the body of glycogen storage. The production of glutamate requires astrocytes, and there is also a very tight link between local or regional blood flow issues in the brain and glucose utilization. And metabolic rates may vary with functional activity. Energy metabolism, neurotransmission are closely interrelated, and all of the neurotransmitters basically are synthesized via glucose metabolic pathways. The relationships are shown on this slide. There's no way as the time to go through this in detail, but it just again wants to make the point in one slide, which is itself worth a 1-hour lecture, the relationships between glucose, blood flow, functional activity, and all of the other issues relating to brain metabolism. Interestingly, in experimental diabetes, changes in brain glucose metabolic rate are very small. We know that increased brain glucose levels do increase sorbitol levels, as expected from our knowledge of the pathophysiology, and also oxidative stress. And we know also that astrocyte gap junction communication is impaired. Regulation of CNS blood flow and functional regional hyperemic responses may be disrupted. But generally speaking, the impact of diabetes is less severe in relation to the brain than it is in other organs. The brain, in particular, is a relatively well-protected organ. Just a couple of slides to speak briefly about type 1 diabetes. And I'm not going to go into this in detail, but just one or two comments to make. Children with type 1 diabetes, they may show subtle decrements in overall IQ, attention, processing speed, and higher order executive skills, and this is particularly the case with early onset type 1 diabetes before the age of 5. This may be associated with lower academic achievement. The causes for this are not entirely clear. Obviously, many different complex issues may be involved, and we can maybe discuss that later if you wish. We do know, however, that one measure of function, the IQ measurement, does show some correlation with hemoglobin A1C, and we also correlate with some documented alterations in white matter structure using modern imaging techniques such as MRI. Now, obviously, this is just an association, and it does not directly address cause and effect, but I think it's an interesting observation nonetheless. The possible risk factors for cognitive change in type 1 diabetes may include the list included on this slide, and again, I'll let you read that just for a few seconds. I'm not going to discuss it in detail. It's obviously a very complicated subject. There seems little doubt, however, that it is related to early age of onset, and also to the presence, of course, of other diabetic complications. Now, moving on to cerebrovascular disease, and again, I will try not to overlap with the topics of the previous speakers. We know from bitter experience that diabetes has major effects on the circulation, and the left-hand column indicates that it's not just atheroma. There are also a number of other different pathological processes going on, and median sclerosis, microangiopathy, autonomic neuropathy, and hypertension are the most obvious of these. As a result, if you look at the red panel, you can see that resulting atheroma, for example, tends to be diffuse, widespread, severe, accelerated, unusual manifestations, and obviously exacerbated by other circulatory pathology. So the brain is not accepted from these particular processes, and as a result, diabetes, as you've heard already, is a strong risk factor for ischemic stroke, with a risk factor in the region of relative risk in the region of 2 to 3 or higher. There is a similar risk for transient ischemic attacks. Diabetes also exacerbates the effects of other risk factors. The effect may be even stronger in certain ethnic groups, such as African Americans and Asians. And also, going back to the Copenhagen City Heart Study, the association is also even stronger in women with diabetes, with a risk ratio ranging from 2 to 6.5. So it's another example where the relative protection shown by women is lost. We also know that ischemic stroke occurs at a younger age, that mortality rates are higher. The ratio of 6 for men and 8 for women, with 16% of deaths in men and 33% in women, directly attributable to diabetes. In addition to mortality rates, there are worse functional outcomes, longer hospital stay. Stroke is more recalcitrant to acute treatment, including recent modern reperfusion techniques. There is a high prevalence of undiagnosed diabetes in stroke patients, and you've already seen that from the previous presentations. And we also know that intermediate dysglycemic states all also increase risk above baseline. Asians, I've already mentioned, may contribute more both to stroke and renal endpoints compared to other ethnic groups. And if you look at the red line in the middle panel, the red line is Asian patients, and this is a subgroup analysis from the advanced study. And you can see that for coronary events and peripheral vascular events on the left, the red line runs at the bottom, whereas for cerebrovascular events in the middle, the red line runs along the top. So there is a particular predilection to cerebrovascular disease in Asian populations. So why is hyperglycemia so bad with cerebrovascular disease? Well, the problem mainly relates to large vessel infarction. And one of the issues is that it's more difficult in the context of all of the diabetic pathology to salvage the penumbra, which is the area around an infarct which is potentially reversible. It's the area surrounding the infarct core. And the reason for that reduced salvage includes impaired recanalization, decreased reperfusion, and increased reperfusion injury. And all of these factors seem to operate together. There is also direct tissue injury risk. For example, there's an increased risk of hemorrhagic conversion. And this is particularly true with big strokes. It's less apparent with lacunar stroke, because in lacunar stroke, the penumbra or potentially salvageable region is much smaller. So I've kind of summarized that on this rather primitive slide, which just shows that if you have a clot, then you will then have an infarct, and that will include an infarct core, which you can't reverse, surrounded by the penumbral region of potentially reversible damage. And in diabetes, the penumbra region tends to be included within the infarct. It's less easy to salvage, whereas in the absence of diabetes, you may be able to salvage that penumbra region and end up with a much smaller stroke and more limited damage. Just sticking for a moment to acute stroke and the issue of glucose lowering in the acute situation. Again, that's been alluded to some extent by the previous speakers, mainly in relation to the heart. But to summarize the situation, there is no clear evidence as yet that intensive glucose lowering improves outcomes. It's still controversial, and most of the studies that have been done are either inconclusive or underpowered. Obviously, it's a very difficult methodological situation. It's difficult to do studies, and the increased risk of hypoglycemia is always an important factor. There is one study looking into this at the moment, which is the SHINE, or Stroke Hyperglycemia Insulin Network Effect trial, which is comparing subcutaneous insulin management with a broad target of glucose values in the region of 80 to 180, together with intravenous insulin infusion and a tighter glucose target of 80 to 130. In both cases commenced within 12 hours of onset. That study is ongoing and may provide us with some useful information regarding glucose lowering in the acute stroke situation. Meanwhile, treat the patient as an individual. Moving on now to cognitive function. Diabetes and dementia. This slide gives you a list of the main differential diagnoses of cognitive loss, with obviously Alzheimer's and the non-Alzheimer's or Alzheimer variant conditions, vascular cognitive impairment, and the very commonly found situation where is there a mixture of all of this pathology. We also know that there is accelerated cognitive decline in type 2 diabetes, and we know, looking at the last point, that the association is stronger for vascular cognitive impairment than it is for Alzheimer's disease, with an RR ratio in excess of 2.5. Looking at Alzheimer's disease specifically, a number of studies have shown a clear link with an odds ratio in the region of 1.5 to 2, but it's important to remember that this may be bidirectional with many interactions, including interactions at the level of treatment. Cognitive speed, episodic memory, executive functions may all be affected. The rates of decline can vary very greatly, from being very slow in some to hugely accelerated in others, leading to clinically frank dementia. It's also important to note that high glucose may increase the risk, even in the absence of diabetes, a dysglycemic state, but the causality evidence remains unclear. A recent study in Annals looked at cognitive decline in midlife and found that in the presence of diabetes, there was a 19% greater cognitive decline over a 20-year period compared with no diabetes. There was also a significantly greater decline among people with prediabetes. There was a worse decline in patients with poorly controlled diabetes and a worse decline in people with long-duration diabetes. All of these are perhaps not particularly surprising, but it does indicate again the importance of prevention and glucose control in the midlife period. The potential risk factors for cognitive impairment in type 2 diabetes are summarized on this slide, and I think most of the wheels around that circle will be recognizable to most of you who deal with diabetes. I might just draw your attention in particular to the issues related here of amyloid deposition, insulin resistance, inflammatory mediators, the pituitary adrenal axis, and on the side here, brain infarcts, functional brain insulin deficiency, and obesity. We also know that there is white matter alteration, which is present in patients with metabolic syndrome, and that these may precede brain atrophy or cognitive impairment. What is the role of insulin in all of this? Well, we know that there are high concentrations of insulin receptors in the limbic system. We know that the beta amyloid oligomers in Alzheimer's disease lead to loss of insulin receptors in the hippocampus. Insulin resistance in the brain then sets up a vicious cycle, which can further promote beta amyloid production. And insulin resistance also reduces the breakdown of beta amyloid oligomers, disruption of which is a hallmark of Alzheimer's disease. We know that insulin is important for cognitive function and that dysregulation of brain insulin plays a role. So it's a very complicated subject, but basically insulin resistance, diabetes, and cognitive decline may be related to reduced brain insulin uptake, impaired glucose metabolism, disrupted regulation of beta amyloid clearance, increased inflammation, and disrupted vascular function with microvascular lesions, and also, as I indicated earlier in the talk, disrupted control of regional blood flow within the brain. There's also bidirectionality here because we know that potentially at least circulating amyloid beta complexes in Alzheimer's disease may increase insulin resistance in the liver by activation of the JAK signaling pathway. So finally, just the last couple of slides before I close, Mr. Chairman, I just want to move on to consider the topic of diabetes and depression, and again highlight the issue of bidirectionality. And if you look at the top red box on this slide, you can see that there is an increased incidence rate of type 2 diabetes in people with depressive symptoms compared to those without depressive symptoms. And if you look at the box further down the slide, there is also an increased incidence of elevated depressive symptoms in patients with treated type 2 diabetes compared to those with other categories of glucose tolerance. So there seems little doubt that there is a link here. Again, it doesn't indicate cause and effect. There is also a relationship between depressive symptoms and higher HbA1c, and I've listed some of them on this slide. I'll run through it quickly because time is getting very short. So risk factors for depression and diabetes include factors operating at every level, both from the level of pathophysiology, such as the HPA axis, pro-inflammatory cytokine pathways, etc., right up to the level of negative expectations. It includes negative effect of symptoms, negative effects of complications, and other issues related to socioeconomics. So a very complicated subject, and as expected, that goes right back to what I was talking about at the beginning, which is cerebrovascular disease. And this study from Hong Kong shows that the presence of major depression actually predicts both cardiovascular disease and stroke and increases the prevalence of these. So in summary, Mr. Chairman, this is the last slide. Cerebrovascular disease, cognitive decline, and depression are all associated with diabetes. There's a complex, very complex interplay of etiological factors in terms of pathophysiology, socioeconomic and environmental factors, and treatment-related factors. And there is bidirectionality in terms of cause and effect at multiple levels between all three of these components. So it's very difficult to tease out one in isolation. So at that point I will stop, Mr. Chairman. Apologies for running just very slightly over time. Thank you for your attention.